I'm Dipan Shah from Houston Methodist Hospital, and here with me today is Dr. Mouaz Al-Mallah, and we're going to be presenting to you on second lecture on cardiomyopathies with a focus on restrictive and infiltrative cardiomyopathies, describing the utility of CMR and also bringing out the role for nuclear cardiology. So before I get started with today's lecture, just a couple of housekeeping comments. For those of you that are watching us live, if you have any questions, please feel free to go to pollev.com and enter the keyword DeBakey, or you can text us your question by texting DeBakey to the number 37607. So let me go ahead and get started today. And this is kind of a continuation of last week's lecture, where we talked a little bit about the role of echo and CMR. And I think one of the key things that we discussed with CMR is this unique ability to directly visualize myocardial damage, not only to identify that it's occurring, but also to see the exact location and pattern. And you'll notice that there's different patterns that can occur, such as a mid-wall pattern, an epicardial pattern, as is shown in the middle here, or a global subendocardial pattern, which wouldn't fit a coronary artery perfusion territory. So all of these cases are examples of myocardial damage that's not consistent with ischemic etiology. And whenever we see these, this is a clue to non-ischemic myocardial damage. As we touched on last week, trying to identify the specific etiology of non-ischemic myocardial dysfunction is important because it has significant prognostic implications and because there can be therapeutic management implications as well. So last week we touched on the genetic and the dilated cardiomyopathies. This week we're going to talk about the inflammatory and the infiltrative and restrictive. So let's start off with a case. So this is a 44-year-old woman who really has no prior past medical history. She presented to the emergency department with 2 episodes of syncope within the past week. She notes progressive fatigue and dyspnea symptoms that have been slowly increasing over the last 6 months, but denies any specific chest pain, PND, or palpitations. On her initial ED visit, her blood pressure is 103/50, but her heart rate is 43 and regular. Physical exam by the emergency physician was noted to be unremarkable. This is the initial EKG in this patient. And you'll notice if we try to look at the P waves and you march those out, you can see that they're independent of the QRS complexes. And really, this EKG is consistent with complete heart block. So this patient then was hospitalized, underwent an echocardiogram, which was unremarkable with normal LV function. And then was really referred for a CMR prior to undergoing pacemaker placement for symptomatic bradycardia. And when we look at the Cine Cmr images shown here, several findings I think stand out at you. One is there's increased thickness in the basal septum. We can see that both in the short axis and on the long axis view. Notice also in the lateral wall, the apical lateral wall, there's increased wall thickness in this area. And then I think also if we look at the RV, we can see an area of focally increased wall thickness within the right ventricle as well. Now obviously the real strength of CMR is being able to couple this with the late gadolinium enhancement, which allows us to identify areas of myocardial damage. And we can see in this patient that there in fact are several areas or foci. There's the hyperenhancement in the basal septum, in addition to that thickened area in the lateral wall, which also shows hyperenhancement, as well as that area in the RV, which shows hyperenhancement as well. When we did our T2 weighted imaging, and these are specific sequences designed to look for increased water content or myocardial edema, we can see in fact that there's increased signal in that basal septum, in the lateral wall, as well as in the RV wall as well, in those areas that were shown increased thickness. Lastly, in any CMR study, we'll always do a survey through the chest, and you'll notice on these black blood images in the paratracheal region that there's these areas of fullness which are consistent with significant lymphadenopathy. So when we put all of these findings together, focal increased wall thickness, the increased contrast uptake after gadolinium administration, areas that show increased water content, along with the lymphadenopathy. This is really a constellation of findings that raises suspicion for cardiac sarcoidosis. And this patient went on to undergo biopsy, which did confirm, in fact, evidence of sarcoid infiltration within the myocardium. So I think, if we go back now almost 10 years ago, there was a very nice study which looked at the patterns of myocardial damage that can occur with sarcoidosis using CMR to identify this in living human beings. And what you'll notice is that really with sarcoid, there is a variety of different patterns. It can be subendocardial, transmural, mid-myocardial, or epicardial, or there can be multiple patchy foci. And in this series, where they looked at a cohort of patients with known extracardiac sarcoidosis, they found that there was CMR evidence of myocardial damage in nearly 1 in 4 patients, despite the fact that by Japanese Ministry of Health criteria, only about 10% of these patients were thought to have cardiac involvement. And as we touched on, the location and the pattern can be very variable from patient to patient, but oftentimes it can also involve the RV free wall as well. And in this single center study, they found, in fact, that those patients with extracardiac sarcoid who had evidence of delayed enhancement on CMR had a worse prognosis when it came to a composite of all-cause mortality, symptomatic tachyarrhythmias, or symptomatic bradyarrhythmias. And then this was followed by a multi-center meta-analysis which looked at about 10 studies with 760 patients, where again the findings were that in patients with known extracardiac sarcoidosis, if there's evidence of late gadolinium enhancement, these patients have a worse prognosis with a higher likelihood of composite events. And so, I think the role for imaging, and specifically for CMR imaging in sarcoidosis, I think is really twofold. One is in patients like the example patient that I presented today, who present with unexplained advanced heart block before the age of 60, patients who have VT of unknown etiology, or patients who have heart failure. CMR can actually be useful to identify the presence of cardiac damage, which can then lead to a clue that the underlying diagnosis may be sarcoidosis. On the flip side, some patients come to the CMR lab with known extracardiac sarcoid, with the question of, is there cardiac involvement in this patient with known extracardiac sarcoidosis? And I think this is an important concept to keep in mind, because many will say sarcoid is kind of the great masquerader, and you really need to have a high index of suspicion to identify it. And in fact, there's some data from patients who underwent transplanted hearts, or LVADs, showing that anywhere from 3 to 5% of patients with end-stage heart failure who are getting advanced therapies may in fact have undiagnosed cardiac sarcoidosis. This was a more recent publication, which was a meta-analysis looking at examples of all studies where there were histologic images available for viewing. And the authors here went through and characterized the location of it, and they noticed several interesting findings, which is one, in the vast majority of the patients, there was some LV epicardial involvement. There was typically multifocal involvement. There was frequently septal involvement, and frequently the right ventricle was involved as well. Let's move on to another condition, systemic lupus erythematous, SLE. And this is one series out of a European center which looked at a cohort of patients who had known SLE and compared CMR findings to a control group. And I think there were two key findings. One is that these patients with SLE can frequently have non-ischemic patterns of hyperenhancement with delayed enhancement MRI. And two, there was frequently pericardial involvement as well, as you can see in the lower right-hand side, where there's high signal uptake within the pericardium, suggesting in fact that there's pericardial inflammation in these patients as well. So let me move on next to the infiltrative cardiomyopathies. And so here's a patient. When we look at the Cine images, we notice several interesting findings. One is there's a small pericardial effusion. There is increased LV wall thickness, which measures about 1.6 centimeters. Notice if we look at the right ventricle, there's also increased wall thickness of the RV as well, which in this case measured about 0.7 to 0.8 centimeters. If we look at the four-chamber view, you can see there's pretty significant biatrial enlargement. This patient has mild LV dysfunction with an EF of 47 and mild RV dysfunction with an RV EF of 38%. And then global LV mass is also quite significantly increased as well. But I think that the key finding here is when you give gadolinium contrast and you do the delayed enhancement imaging, what do we notice? We see that there is really diffuse contrast uptake both in the left ventricle as well as in the right ventricle. In fact, when we look at the four-chamber and three-chamber views, you can also see significant contrast uptake within the left atrium as well. Notice if we go back to the LV, the papillary muscles also show significant hyperenhancement. And this is really a classic finding that you see in patients who have amyloid heart disease. And this finding in patients who have known extracardiac amyloid, the presence of cardiac involvement based on late gadolinium enhancement is associated with a worse outcome. This is a single center study almost 10 years ago, showing in fact that the absence of LGE is associated with a much better outcome in patients with known extracardiac amyloidosis compared to the presence of any late gadolinium enhancement. And in fact, it was better at stratifying than NYHA class was. And this was followed by a multi-center study that we were involved with, which again found that across a spectrum of patients, having any hyperenhancement in a patient with known extracardiac amyloidosis is associated with a much worse survival. And again, the pathophysiology of this, although with amyloid there's not necessarily a destruction of myocytes, there is deposition of protein in the extracellular space, which really leads to an expansion of the extracellular compartment, as is shown in this nice cartoon here. As we know, gadolinium is an extracellular contrast agent, so the amount of gadolinium within any given area is going to be directly related to the amount of extracellular space. So therefore, patients with cardiac amyloidosis have a greater uptake of gadolinium than do patients with healthy myocardium. And as a result, we can actually use this principle to do even more quantitative mapping using a technique called extracellular volume fraction, where we can see that typically patients with cardiac amyloidosis have a very high or very large extracellular compartment, and typically the extracellular component is 40 or 50% of the total myocardial volume. But I think it's important to keep in mind that although some of the classic example cases I showed you of cardiac amyloid involvement, we can also have a patient like this who we can see has increased LV wall thickness, but has a much more non-pronounced pattern of hyperenhancement, again, in multiple segmental areas. This patient also went on to undergo biopsy and was found to have ATTR amyloidosis as well. So I think really keep in mind that we may be seeing patients at different points in the pathophysiologic spectrum, and again, you need to have a high index of suspicion. Here's another case. Another example case is a 29-year-old woman who is African American, who's admitted with a pneumonia and retrosternal chest pain. And I'll tell you that this is a case that's before the era of COVID-19, so that's not in the differential, although today certainly we need to keep that as a possibility as well. She has an elevation in her cardiac enzymes. Troponin peaks at 2.67. When we look at the Cine MRI in this individual, we notice that although overall LV function looks relatively preserved, there does seem to be an area of focal increase in wall thickness here in the anterior wall. And you can see that in the basal as well as the mid-anterior wall, even extending down a little bit to the apical anterior. And if we look at our three-chamber and specifically our two-chamber views, you'll notice this focal increase in wall thickness to be present. But again, I think the real strength is if we couple this Cine imaging, which allows us to look at morphology and function, with delayed enhancement MRI, which allows us to do tissue characterization. You notice, in fact, that this area in the anterior wall that has focal increase in wall thickness actually has a very unique pattern of enhancement. And what you'll notice is that there's a small rim of bright followed by an area of dark, and then another rim of bright right here. As you can see, this kind of three-layer pattern that you see. And again, this is a classic finding that you'll see in eosinophilic myocarditis. This person, in fact, when we looked at her white count, was 20,000 with about 67% predominance of eosinophils. And this, again, is a finding that you see in eosinophilic myocarditis or Loeffler's. This patient, I think the advantage of establishing this diagnosis, or at least raising the suspicion of this, is because from a therapeutic standpoint, this patient now went on to receive high-dose steroids as well as anticoagulant therapy. And you'll notice, compared to the initial scan, when she's brought back for follow-up imaging at 3 months, that focal increase in wall thickness in the anterior wall now seems to have resolved. And when we do delayed enhancement MRI, we can see now there's not that classic three-layer pattern of enhancement that we saw before, of enhancement, hypo, and further enhancement, except for in this small little area right here in the anterior wall. So it looks like most of this has actually regressed with therapy. And let me move on to another condition, and this is siderosis. This is iron overload. And here's some examples of several different individuals. The individual on the left here is somebody who's 45 years old, has a diagnosis of idiopathic cardiomyopathy. When we do the CMR iron overload technique, which we call a T2 star mapping technique, there's no evidence of iron overload in the heart or the liver. And again, one of the classic findings that you'll see with iron overload is it causes the myocardium or the liver to appear very dark on many CMR sequences. This patient in the middle here is a 35-year-old woman who has a history of sickle cell anemia. And in this patient, the cardiac or the heart showed evidence of iron overload. And in addition to that, liver mapping also showed evidence of iron overload within the liver as well. And then compare that to this third patient on the right here, who has normal iron content within the heart, but abnormal iron content within the liver. So I think, you know, the technique that we use in CMR to try to actually quantify the extent of iron content is this technique called T2 star mapping, which allows you to come up with a quantitative measure which relates to the extent of iron within the specific tissue. And this technique really has been around since the late 90s when it was developed and really implemented in the UK to start with. And I think there were several interesting findings from this study which looked at using CMR T2 star mapping in patients that were receiving iron chelation therapy. And there were several things they noticed. One is that in patients who have advanced iron overload cardiomyopathy, it can actually be reversible with iron chelation therapy. Second is that the CMR measures that we see, which is again what we call the T2 star measurements, actually improves in concert with improvements in LV volumes and LV function in these patients when they're getting iron chelation therapy. And I think third, that iron clearance was significantly faster from the liver than it is from the heart. And I think that's where the real advantage of having this ability to estimate the iron load within the heart is important, because with administration of chelation therapy, the iron may be resolved from the liver very quickly, but it may take much, much longer for it to clear out of the heart. And so the ability to not just look at iron content within the liver, which has been done before, but to be able to look at it within the heart, which really has only been around for the last 20 years or so, I think helps to improve the management and tailor the management of these patients. And I think that's really shown nicely by this publication out of the UK, where they looked at the incidence of death in patients with thalassemia in the United Kingdom. And you'll notice that the vast majority of these stats in these patients were really from iron overload. And then with the advent of this CMR T2 star technique to guide management, there was a significant reduction in the iron overload deaths, and as a result, a significant reduction in cardiac deaths in general, to the tune of almost 71%. So I think this is a great example of where imaging can guide management to actually help improve patient prognosis. Now, let me wrap up here with just the last couple slides. This is an example of a patient with Anderson-Fabre disease where there is this predilection of hyperenhancement that's seen after contrast in the basal infralateral wall. This is a study now that's almost 20 years old. And I think as we apply some of our newer techniques where we can actually look at the quantitative T1 measurements of the myocardium, as is shown in this series, you'll notice that with Anderson-Fabre disease, where there tends to be a lipid deposition, that there's actually a shortening of the T1 times. And in this series here, where they looked at a cohort of patients with Anderson-Fabre's intermixed with hypertensive, hypertrophic, valvular AS, or amyloid cardiomyopathies, there was a pretty nice separating line that separated out those patients with Anderson-Fabre disease where there is a decrease or lower myocardial T1 time versus most other conditions which are in fact associated with an increase in myocardial T1 times. And this, I think, brings us back to the schematic cartoon that I presented at the very beginning of last week's lecture, which is I think that the tools that we have with CMR, I think beyond just being able to look at morphology of the ventricle and function, is the ability to look at myocardial fibrosis using the late gadolinium enhancement CMR technique, and then coupling that now with newer T1 mapping techniques, which can allow us to get an idea of what the native T1 time of the myocardium is, as well as to determine what the extracellular volume or extracellular compartment of the myocardium is, which I think allows us to really try to nail down specific diagnoses, or at least generate a differential diagnosis. And so I think to kind of wrap up, you know, what hopefully in the last few weeks we've talked about is that with CMR, with this direct ability to visualize myocardial damage, you're actually able to identify a subendocardial or transmural pattern of hyperenhancement, which is suggestive of an ischemic etiology of myocardial dysfunction, versus patients who have a midwall, an epicardial, a global subendocardial, or kind of multifocal pattern of myocardial damage, which occurs in a variety of different non-ischemic conditions. And really, it's this ability to directly peer into the myocardium in this way that allows us to be able to narrow down a differential diagnosis in these patients. So to wrap up, I think where CMR is helpful is this ability to do tissue characterization via late gadolinium enhancement, as well as the ability to do T1 mapping. I think aids in diagnosis, prognosis, and has therapeutic implications in patients with non-ischemic cardiomyopathy. So I'm going to pause there. Mouaz, can we get you to can we get Mouaz's microphone on? And let's have you go ahead and share your slides. And then you're going to talk to us a little bit about the role of cardiac PET in cardiomyopathies. And then hopefully we'll have some time for questions. And again, while Mouaz is getting set up, for those of you in the audience, text your question to 37607 and text DeBakey, or go to pollev.com and enter the keyword DeBakey. So Mouaz?
Do you see my slides?
Yes, we can see your slide. If we can just get you a little bit louder.
Thanks, Dipan, for the introduction. And if I was giving this lecture about 10 years ago, probably it would have been completely echo and CMR for assessment of cardiomyopathies. And nuclear cardiology was probably not involved in the assessment of these patients beyond ruling out coronary artery disease. However, over the past 10 years, there have been a lot of advances in the field of nuclear cardiology, which allows this modality to fill some unmet needs already that have been still required for the management of these patients. I'm going to focus today on two conditions: inflammatory cardiomyopathies, which Dipan has fully covered in depth the role of cardiac MRI in there. And this is, for example, one of my patients who presented with non-sustained VT, requiring multiple shocks, and the CMR shows a pattern which is very suggestive of cardiac sarcoidosis. However, we don't know if we image this patient after some time, whether this is going to go away or remain there. And if you image the patient, you don't know how active is this VT because of scar or because of active inflammation. There are some tools in MRI that can help, but I'll show you here the role of FDG PET in the assessment of inflammation. I'm going to start a little bit with the protocol because it has a lot of implications. The heart likes to use glucose, and to be able to image inflammation in the heart, we need to suppress the myocardial glucose uptake. And right now, the way to do it is that to give patients a low or no carbohydrate diet, ask them to fast for 12 hours. Then we can move forward on the next day, do a perfusion imaging when they come to the lab. We inject heparin because it increases the level of free fatty acid in the blood. Wait for about 15 minutes, inject the FDG, wait another 60 minutes for the FDG to get to these inflammatory cells, and then do the FDG imaging. And these type of the typical examples that we get when we do this imaging. I'll start with the normal pattern because when we do inject the FDG and there's complete suppression of the myocardium, you see that there is no FDG uptake in the myocardium, and you just see a negative image of the myocardium, and all the FDG is in the blood, which we call the blood pool. And if you take a look at it on other traditional displays where you see now this is a blood pool which is empty on perfusion imaging, or there is no rubidium or radioactive material there. And on the FDG images, you see all the blood pooling that you see there. In contrast, when you do it on a patient who has active inflammation, now you see two patterns. First of all, when you do the perfusion imaging, there is a perfusion defect. And this is because of all the sequelae that's happening with inflammation, edema, and potentially scarring in these areas that you see with late gadolinium enhancement on MRI. But when you do the FTG, now we have suppressed the normal myocardium from getting the FTG, and all this FTG is going to these active inflammatory cells that are sitting in that area. So these images are kind of complementary and fill each other. So you see perfusion defect in the basal septum, and now you see FTG uptake in this area. We can see FTG uptake also on the left atrium and other areas, and recently we've been paying more attention to this because this might help us also in establishing the diagnosis. So this is an FTG uptake in the left atrium. You can also see it in different views, focusing at for example, the basal septum in this patient here. You can also look extra in the right ventricle. So you see on MRI late gadolinium enhancement, and you see it here on the FTG where there is septal uptake. You can see it also extracardiac outside the heart, like in the lung, or it could be even more exaggerated, as in this example from our lab where the patient had very active pulmonary sarcoid, which was almost mimicking cancer in this patient. So when we do the study, what type of pattern we see? We can see a normal study where there is normal perfusion and no FTG uptake. And sometimes we see a diffuse FTG uptake because we failed to suppress the myocardium. So all the FTG went to the myocardium. So here's one example. Patient has no perfusion defect, looks very normal in terms of perfusion. When we did the FTG, we see the diffuse FTG uptake. We didn't believe this. We felt that this patient did not follow the diet very well. We asked the patient to come back again. after 2 weeks and follow the diet, and still we could not suppress the myocardium. So you can clearly see in this patient, we failed to suppress the myocardium, whether it's a diet issue or the patient did not follow, was not compliant with the instructions. That's another thing to be determined. On another hand, this is another patient that you can also see that there is a basal septal perfusion defect, anterior interseptal defect. When we did the FTG images, there is like more homogeneous FTG uptake all through. And we felt that this could be dietary uptake because the patient had normal LV function, and she also had an MRI before which showed only limited scars, so only in the basal anterior septum. And now we're looking at very diffuse FTG uptake, so we did not believe in it, and we asked the patient to follow the diet again and come back. And a week later, without any change in therapy, you can see that the patient was very religious about following her diet, and now we have a normal study. So it's a huge difference between calling a study very extremely abnormal and a completely normal study with a scar but no FTG uptake or no active inflammation. So this one was a poor preparation issue. Now, when we talk about the abnormals, the most significant one is where you have a perfusion defect and complementary FTG uptake in that area. And this is where it is the most specific. In fact, when looking at how you classify cardiac sarcoidosis and looking at possible or probable or highly probable, this one is probably the most probable, where you have a perfusion defect and FTG uptake in the same area. Or if you see it in the very first pattern I showed you, where there is significant scar in the MRI involving the involving the RV, or you see it as in here where you have multiple perfusion defects and multiple FTG uptake in these areas. And this pattern, when it was compared among those patients who went for transplant, and when they looked at those 18 patients who had their heart explanted, about this had a high sensitivity of nearly 100% for sarcoidosis. Now, specificity was less, and this is because a lot of these, you can see it also with inflammation. But when you see it very specific with the perfusion defect, that's very sensitive for detecting inflammation. We recently even had, this is another case where you see a perfusion defect and there is FTG uptake complementary to it. And this is among this patient who went for heart transplant. And you can see these non-caseating granulomas. We recently had a very similar case, this patient I showed you before, who has extensive FTG uptake in both the LV and left atrium. This patient actually had multiple biopsies. All of them came back non-specific. He was treated and there was some improvement in his FTG uptake, but not complete resolution. Eventually, the patient was transplanted, and on the explant, there were non-caseating granuloma, confirming the diagnosis of cardiac sarcoidosis in this patient. So the presence of FTG uptake is prognostic, similar to what we just saw with CMR and late gadolinium enhancement. And when you have both abnormal, the rest perfusion and FTG uptake, that is actually the worst prognosis in these patients. Now, how does it fit with cardiac MRI? And you can see most patients we have actually end up having both because of their complementary nature. So a cardiac MRI is probably more often used as a first test. This is a patient who actually had sudden cardiac collapse and ventricular arrhythmias. You can see multiple areas of late gadolinium enhancement. And these areas are the same areas that light up on FTG. So you can see the FTG uptake in these areas. And how do we kind of triage which test to do first? And this is a ongoing research and trying to find out which patients need both versus need one of them. The general consensus at this time is that you're going to start with the CMR. If it is normal in a low-risk patient or low clinical suspicion, then you can potentially stop. However, if the MRI is abnormal, then you can go to PET to look um, for active inflammation. However, if your suspicion is pretty high from a clinical standpoint, then you should proceed to PET. For examples, I'll show you later. And you can do it on a hybrid PET-MR, as in some centers have it, or you can potentially, hopefully will have the tools that will allow you to fuse it afterwards and come up with images like this. So this is a patient who have a scar in the basal inferolateral wall. There is significant FTG uptake in this area, and there is a perfusion defect with decreased ammonia uptake in that territory. And there are other cases from the literature where here you have a patient who actually also have a PET-MR and a PET-CT. And here you see late gadolinium enhancement in the basal inferolateral, and there is no uptake on the PET-MR. And this is a patient who already had a scar, but there is no active inflammation. So there is no need, or the immunosuppressive therapy is not urgent at this time for this patient. On the other hand, this is a patient with higher clinical suspicion, early type of disease, where late gadolinium enhancement is still normal, and you can see significant FTG uptake in this patient. Now, when we see this, we always raise the suspicion for poor preparation. However, this patient eventually by biopsy turned out to have, according to the literature, turned out to be a cardiac sarcoid patient. So these are the different patterns I'll show you if you're going to combine both PET and MR. Like this is a patient with subendocardial scar. So this is a transmural late gadolinium enhancement from an infarct. These are two studies are normal. So this is a normal scan. This is a patient who have a normal MRI and diffuse FTG uptake. And this is a patient who is poorly prepared. And this is a patient with normal late gadolinium enhancement, high clinical suspicion, and very intense focal uptake in the basal inferolateral. And this patient actually, according also to the publication, turned out to be a positive cardiac sarcoid. And these were obtained on a PET-MR system, so these are simultaneous acquisitions. So in early cases, you may end up having negative late gadolinium enhancement and positive MRI. The second scenario, which we had a recent case here, where the patient could have complete heart block. This patient had no late gadolinium enhancement on MRI. Now, and you can see here that there is a very small focal uptake at the basal inferolateral at the basal septum, and you can see multiple lymph nodes in the chest. And this is a patient who has an uptake probably just at the AV node, resulting in complete AV block. And this is where, now this is not the entire AV node. This is like, because of very intense uptake, you see it like more of a light blowing, so it's a little bit bigger here, but this is like exactly where the AV node could be. Now, how do we follow it up? This is one of the patients I showed you earlier. This is his MRI. So the patient was put on therapy, and on follow-up 3 months later, he has no FTG uptake in the myocardium, and there's complete resolution of the inflammation. And now the patient has all he has is blood pool. So this is his pre-therapy, and this is post-therapy. And this is where PET could help, another unmet need, which is following up these patients for therapy. And this is what we call the Kasi effect. Our doctor here, Dr. Kasi, is the one who's following these patients and giving them aggressive immunosuppression for this patient, steroids and Celsep. And you can see here, if you put it on the fused images, you see the FTG uptake in the LV, in the septum, and on follow-up, it's all gone here. Now, interestingly, this patient had an MRI after, and there is decrease in the late gadolinium enhancement. Now, I have to tell you that this patient had an ICD in between, so the images may not look as nice, and this one is the effect from the ICD that you see here. But there is still some late gadolinium enhancement that you see did not change. And these were done in 2 different machines. So but there are some interstudy variability, but you can see that there is still late gadolinium enhancement in this patient, despite no active inflammation. So the late gadolinium enhancement either take longer to at least regress a little bit, or may never go away, depend on what was the etiology of it, whether it was a scar versus edema and increase in the extracellular volume. Now we can potentially quantify these. So here you can see this is another patient, the amount of inflammation that was there. With therapy, it shrunk, so it did not go away. So this is another patient where it did not completely resolve, but you can see significant reduction in the amount of inflammation and also significant reduction in the SUV. And we're trying to at least now try to figure out how much, like how do you define the response? So the SUV went down from 8.4 to 7. The mean went down from 3 to 2.2. The extent have decreased. So which one would you take to define improvement? And this is an area of ongoing research, but clearly there was significant improvement and decrease in the amount of inflammation for this patient. And every now and then we get some interesting cases. So this is another patient who you can look at, and you can see here in the pericardium there is intense inflammation. And this patient was sent because of concern that there might be concomitant inflammatory cardiomyopathy. There was none in the heart, but you can see now we detected the inflammation in the pericardium, where you see the same area as the late gadolinium enhancement in the pericardium. So we're not only looking at the myocardium, we can look at it in the other structures, in the aortas, and other inflammatory etiologies. So I want to make a point here that this is, again, not pathognomonic for sarcoidosis. We're imaging inflammation, so this could be a sarcoid, but this could be also other etiologies, including other etiologies like Wagner granulomatosis, lupus carditis, and other inflammatory cardiomyopathies. So I'm going to switch gears to another area where now nuclear cardiology is making a difference, which is amyloid imaging. And obviously, if you are in the field of cardiology, you have seen all the advances in the field of amyloidosis based on the newer diagnostic tools, but also newer therapeutic options for these patients. And I'll start quickly with a case. This is a patient who has, obviously, based on the case that Dr. Shah just presented, which clearly shows that there is thickened ventricle, there is biventricular thickening, reduced displacement of the mitral annulus, significant mitral regurg. The whole heart is stiff, and when you do late gadolinium enhancement, there is diffuse late gadolinium enhancement indicative of amyloidosis. At this time, when you see such a patient, you want to know what type of amyloidosis you have, because the treatment is going to be different. One of them could be the ATTR amyloidosis, which actually can be treated, which can be genetic versus sporadic, and this has very different treatment than the AL amyloidosis, which is more considered a medical emergency and requires chemotherapy. It's less often encountered, but it is very important to make the distinction. Unfortunately, right now, MRI is not able to make that distinction, and that's why you need to make that distinction. First of all, you need to do the protein analysis, kappa and lambda, to make sure that there is no AL amyloid. After that, now you have to proceed to Pyp imaging to differentiate between the AL and ATTR. As you see in here, AL has no uptake versus ATTR, which has significant uptake in the myocardium. Now, what is PYP? Because you see the vertebra is lighting up, you see the ribs lighting up. PYP is actually a bone scan, different than the agent used currently in bone scanning in the US, but it is another bone scan agent which has been approved for blood pool imaging, for even cardiac imaging to detect myocardial infarction, and for bone imaging. So it's an agent used for bone scan and has been long thought to be uh, helpful to use it for imaging for amyloidosis. However, prior results, even 20 and 40 years ago, were disappointing because the differentiation between AL and ATTR amyloid was not very well known. Now, there is no specific preparation for this test. The only contraindication is if the patient is claustrophobic, which you can manage very little claustrophobia with nuclear scans. You want the patient to lay on their back for 30 minutes, probably, and poor eye if there is, you cannot inject the material, and if the patient, if allergic, which is extremely rare, I'm yet to see one case of that. So technically, there are no real contraindications for PYP imaging. And once you go ahead, you do the images in planar, and now we're going to talk about doing also more SPECT. When you do the images, you reconstruct them. So you can see this is a bone scan agent. So you see the ribs lighting up. And we try to come up with a grading for them, the Burkini grading, which is looking at the heart and compare it to the ribs. So if there is no uptake, like in this patient, we call it the grade 0. If there is uptake, but it is less than the ribs, we call it grade 1. Grade 2, if there is uptake which is equal to the ribs, and grade 3, if there is uptake which is more than the ribs. So this is how the field started, and this is only 6-7 years ago. And this paper I'm quoting you for these images is very new, and we're trying to see which one would correlate with or suggest cardiac ATTR amyloid. And now the notion is that if it's grade 2 or 3, this is where it is highly suggestive. Now, as you know, in cardiology, we like numbers, we like heart rate, blood pressure, wedge pressure, so we want to come up with a number. So the convention that was used is that you draw an ROI over the heart, you draw an ROI over the contralateral lung, and you measure the ratio of this one versus the other one. Region of interest here, and if the ratio, so you take the ratio of this, for the heart, you divide it by the ratio on the contralateral lung. If it is above 1.5 at 1 hour, then this is diagnostic or highly suggestive of ATTR amyloid. If it is less than that, then it is less than 1.5, then it is less suggestive. And this is where a multi-center study was put together looking at 1,200 patients in multiple centers, but you can see that this is like a little bit of a higher probability cohort because these are patients who had heart failure with typical echo or MRI finding of amyloidosis, and looking at those who have grade 2 or grade 3 uptake and absent monoclonal protein in their serum and urine for the sensitivity and positive predictive value, where the specificity and positive predictive value were 100%. Now, these numbers may look too good, so if you look for a meta-analysis of 6 studies, 529 patients, the sensitivity was about 92%, specificity of 95%. So this is very good comparing the disappointing results before from biopsy and the lack of another tool beyond echo and CMR for them to make such a diagnosis. Now, it even predicts outcome. If you have a heart to contralateral ratio less than 1.6, then it is better prognosis compared to those who have more than 1.6 in terms of outcome for prediction of all-cause mortality. Now, as I told you, this field is evolving right now, and there are some issues that are currently being considered or trying to figure out what's the best way to do it. So some studies, when this field started, were using 1 hour wait. So between the time you inject the patient and the time you image them, they were using 1 hour. Other centers did 3 hours. Now, if you look at the diagnostic accuracy, the AUC of the 1 hour was 0.94. It was 0.98. Both of them are great, but still a little bit better with the 3 hour. Now, how can we consolidate that and put it all together? So this is where the role of SPECT imaging comes instead of just doing planar imaging. And for those who don't do planar or nuclear cardiology, think of planar imaging as your chest X-ray and SPECT imaging as your CT. So now you have more in-depth details and you have a third dimension. And when you look at it, for example, this is a patient which was lent to me by Dr. Brett Sperry, where the ratio was 1.6 at 1 hour. At 3 hours, it's 1.4 almost, and we use a 1.3 at 3 hours to look for significance. But when you look at the SPECT images, there is no uptake in the myocardium. This uptake is all in the blood pool, suggesting that this is not coming from the heart because this patient has low ejection fraction, and the PYP signal that we're getting is all coming from the blood pool. Here are some examples from our lab. So here you see a patient at 3 hours, a heart contractility ratio of 1.6. So this one you're pretty sure, but you still want to confirm that this is not a blood pool, especially in low ejection fraction patients. And when you do a SPECT imaging, you can clearly see that the uptake is in the myocardium. Now, we some tips when you are doing this, you try to avoid the overlap with the bone because the bone will have more PYP. You want to distinguish the blood pool from myocardial activity. You look at the distribution of PYP uptake, and you also try to focus on the septum because this is where most of the uptake is going to be, and usually more in the basal segments, and always have a good view of the ribs. So this is, for example, now we're using a SPECT CT for this because it will help guide us to where the heart is and where the septum is, and you can clearly see here that there is a hot septum in this patient and more the uptake here, and this is like more uptake also in the vertebra, which because it's a bone scan, and this is a patient clearly with amyloid, with ATTR amyloid. This is another patient at 1 hour, 1.57, at 3 hours, 1.5. You can see here that these patients, we want to make sure that this is not from the blood pool. So when we do the PYP scan, you can clearly see it's coming from the myocardium. In contrast, this is another patient, 59-year-old, who has a PYP at 1 hour, 1.5, the ratio. But when we look at it, you can see all the uptake is in the blood pool. Now, this case was really tough because she has a typical MRI suggestive of amyloid. Now, we looked at 3 hours because we are still looking at these cases, and now we are still at 1.3, so it's at the cutoff. But what this 3 hour and the prior 1 hour clearly confirm that there is no uptake in the blood pool. And because of the MRI and because of her presentation, I was asked to relook at the images and make sure that are we missing anything? And this patient actually had a biopsy, and the biopsy came out to be AL amyloid. So even though 1.5, but still the uptake is more in the blood pool. So I'm focusing on this issue of blood pooling because this is probably the most common cause of false positive that I'm seeing in these scans. But there are many other causes of false positives, including AL amyloid, which may be positive in about 4%, hydrochloric twin toxicity, where we had one case in patients who have rib fractures or pleural effusion, valvular calcifications, blood pooling, breast implants, so it will cut down the counts on the other, on the contralateral lung, recent MI, or there are some mutations. And there are some other causes of false negatives. So I think with PYP, it may appear to be a simple in terms of preparation and interpretation, but you have to be look at the entire case, look at the other imaging, and confirm that the uptake is primarily in the myocardium and not in the blood pool. And and we are shying away now from the ratio because of all the technical issues that may potentially go wrong with it and may give you a number which may not represent what is in the case. So focusing more on the fused images or SPECT images will help you delineate those cases that are positive, truly positive in these patients. And finally, one word about the amyloid in PET. So there are multiple PET tracers that are being studied. They are not used clinically right now for cardiac, but they are used primarily for brain or other organ involvement. One of these agents is flubitabir, F18. And here, where in this case, where you have in control no or minimal uptake, some uptake in the ATTR, but it's extremely helpful in patients with AL amyloidosis, where the uptake is more significant and may help also in other organs like pulmonary and otherwise. And you can see here when you do quantification, there is a gradient where the amount of uptake is very different between the controls with minimal uptake, where some uptake, but there is good separation between the ATTR and the AL amyloid in this agent. So this is an area to watch, and hopefully one time we will get it to become clinically helpful in some patients where PYP still is unable to identify the proper differentiation between AL and ATTR in some problematic cases. So with this, I'm going to stop, and I hope I showed you that nuclear cardiology as a field is evolving and is supplementing the great work or the great information that you can get from echo and MRI in these patients, with these difficult patients with different cardiomyopathies. With this, I'm going to stop, and we're happy to take questions.
Great. So Mouaz, we've got one question here from the audience. Here's a question. It says, for sarcoid, particularly when looking for active sarcoid, why not start with PET as opposed to CMR? Is the sensitivity higher with PET, as shown in some examples?
Yeah. So PET, I wouldn't say it's sensitivity. We're looking at two different things, because in sarcoid it could be active right now, but may have, like, you don't know. When you are doing PET, you're just detecting disease activity right now. But if you're trying to make a diagnosis of cardiac sarcoidosis, you want to know the activity right now, but also if there are prior episodes. And as I showed you, in some cases, once a patient develops one episode of cardiac sarcoidosis, there will be some remnant late gadolinium enhancement in these patients. And that's why it's helpful to detect these, because even if you detect late gadolinium enhancement without FTG uptake, you still have established a diagnosis of cardiac involvement, not right now, but may have been in the past. And remember, the presence of scarring in these patients is going to does have prognostic implications for these patients.
Okay, great. So there's another question from the audience here as well. It says, does a negative monoclonal antibody workup plus highly suggestive PYP study exclude necessity to perform organ biopsy to confirm ATTR amyloid?
Yeah, I mean, so right now this is being proposed as the non-invasive biopsy for amyloid. So if it is convincingly, and if you've done SPECT-CT, you have negative kappa and lambda, and you're sure that there is no AL, and you have a diagnostic PYP, yes, you can potentially skip biopsy and proceed to therapy in these patients. But again, I cannot emphasize more because the therapy is long-term, very expensive, and has potential long-term implications. I think it's extremely important that we are pretty sure. So we want to have the highest quality in these studies and do a SPECT or SPECT CT if possible, and not just rely on planar images for these patients before committing to long-term therapy.
And maybe let me ask you another question, and I think you touched on this before. One of the pitfalls or limitations with PYP, which is a recent MI. So I think most of our fellows are probably not aware of it. This goes back now many years when I think people were doing PYP scans specifically for that reason. I guess the question would be, what do you define as recent MI? And the second thing is, I think that's an important thing to bring up, because we've had cases where a person who has a background of an infiltrative cardiomyopathy who comes in with acute coronary syndrome, and that can then cause confounding to your PYP results. Maybe I thought it'd be a good chance to touch on this a little bit more.
Yeah, so this is very important. Again, I don't know on the top of my head, like what is recent cutoff. I think Dr. Mamarian can ask him offline, because he used to do a lot of research on this area and many years ago. So, but I would say within the first month or two, this is where the active remodeling and the acute inflammation is happening. I would be very careful, but still I would probably, it's going to be more limited to the area of the MI. So if you have like an anterior MI and now most of your PYP is in the inferior wall, that still can help you. So I wouldn't completely rule it out from being done, but you have to be very careful about that caveat in there. I'm sorry, what was your second comment about that?
Well, no, it was just that for folks to be aware that if you're trying to use a PYP to determine, okay,
Yes.
is this ATTR versus AL, then the key is going to be to make sure that this is not in the backdrop of an acute coronary syndrome, where it could maybe drive your values higher, your ratio higher, especially if you're just doing planar imaging, right?
Yeah, and it's very important. I mean, this is not for the minor troponin that comes in these patients with HFpEF when they got admission. I mean, this is a true acute coronary syndrome, plaque rupture, and anterior MI or inferior MI in these patients. So we're not talking about the kind of type 2 MI demand ischemia. We're talking about the real acute coronary syndrome from plaque rupture.
Okay, I think we're a couple minutes past time, and I want to thank everyone for tuning in today, and thank Mouaz for joining us, and we'll see you all again next week.
Yeah.
Thanks.